and Dr. Sri Lakshmi. So without much delay, shall I ask Dr. Shaji Hussain to start his presentation? He'll be talking on how to choose your patient and how to see the warning signs regarding the profile of the patient who is eligible for refractive surgery.
Good afternoon, everyone. As you know, the topic as a whole is about refractive surgery, and my role is to customize these refractive surgeries based on patient profile. To begin with, refractive surgery, it's moving? Yeah, okay. So to begin with refractive surgery, there are two mainly based, laser-based and non-laser-based. Laser-based was PRK photorefractive keratectomy and laser in situ keratomiliosis. The non-laser-based systems are intraocular columnar lenses. It's moving without me pressing. It's going. No. Sorry about that. No. Okay, so the absolute contraindications are animation timing, is it somewhere? Okay. The absolute contraindications are when you have a okay, I think. Okay, the absolute contraindications would be when you have an unstable refraction, and if you have corneal abnormalities like corneal ectasias, corneal vascularizations or interstitial keratitis, and if the cornea is not adequately thick for the resultant ablation, if the patient has, it's moving fast. Okay. Oh, okay. Double click that. This one. It's fine. Okay. So uncontrolled glaucomas, autoimmune corneal uncontrolled autoimmune diseases, and when patients have lid margin diseases, or patients who have uncontrolled depression and high patient expectations. So the relative contraindications would be when the patient is having monocularity, excessively steep or flat corneas, abnormal corneal topographies, significant irregular astigmatism, history of uveitis, diabetes mellitus, pregnancy or lactation, and age under 21 years. So the refractive errors that should be corrected are with regard to laser-based procedures when the powers are less than -6 diopters, and we can between -6 to 8 we can use laser-based as well as intraocular columnar lenses, and when the powers are above 8 we can usually opt for a intraocular columnar lenses, and because there are more higher possibilities of post-LASIK ectasias or regression of the powers. And if the age is above 40, we can also recommend clear lens extractions. And here the EDOF lenses are doing a great job. In hyperopes, the power recommended would be a power less than +3, and make sure the orthoptic evaluations are very well taken care of. Otherwise, usually the +3 powers, patients regress quite often. So in case of LASIK, what are the parameters we usually keep in mind? We know that there is a laser, examer laser is being used and a flap being elevated, and the stromal is being ablated and the flap is placed back. So the first thing we keep in mind is the RST, that is the residual stromal thickness. And the first thing is the total corneal thickness. We know this is the corneal thickness, and this is the flap that is being elevated, and this is the stroma that is being ablated, and this is the residual stromal thickness that remains. So I usually keep an RST of 300 microns as a cutoff, and the flap thickness that I usually take is 130 microns. If it is the RST is not meeting up to that, I make my flaps thinner to 110 microns or 90 microns. With regard to stromal ablation, it depends on how much power is being ablated. That can be taken up from this from the Excel sheet that is provided by the machines. Like if it is -0.5, this is the micron that is being ablated. If it is -1, 27 microns, and this is the cylinder. So accordingly, we will know how much of stroma is being ablated. Now this is for different optic zones, and now as the powers are going on the higher side, the amount of ablation that is are also increasing, and accordingly the RST will be decreasing. So when you have the RST is not meeting up, then we'll make the flaps more thinner, and we can also change the optic zones based from 6 and 6.5 usually based on the pupil size, mesopic pupil size. Usually in Indian patients we keep it at 6, and if Middle East patients they have a larger mesopic pupil size, we make it 6.5. The next thing we have to keep in mind after the residual stromal thickness would be the post-op K, and we know the corneal usually having a curvature between 42 to 46, and in post-LASIK we flatten it up, and the cornea should not get more flatter than 34 microns. The next is the flat. We should not be using a keratome based procedures on a flat corneas that is less than 40, and also on steep corneas that is more than 48 diopters, because in flat corneas we can highly get with a keratome we can get a free flap. For steep corneas we can get a buttonhole. And the next thing we have to keep in mind is the percentage of tissue that is being ablated, and here that is telling us the amount of cornea that is being weakened by raising a flap and by doing the stromal ablation. The cornea that remains should definitely be more than 40%. It should not be the area weakened should not be more than 40%, because this can result in post LASIK ectasias. So the numbers to be remembered for RST would be 300. It is currently according to the preferred practice patterns in AO, it is 250 now, and PTA is 40 and 34 for the flat case. Now let's say if there is a Google app that is being I have made to calculate all this in one go, and we can just enter the power and it will just tell us how much is the PTA, RST and post-op case. It can be easily calculated by the optometrists themselves. So if the patient is not fit for LASIK, the next thing in option we would have is PRK, photorefractive keratectomy, and here it is nothing but we are debriding the corneal epithelium, ablating and placing a contact lens, and here the RST I usually keep is around 400 microns. We will have a little more stroma to play with in PRK. So these are the two refractive. Third one would be the ICL, and the next one would be the clear lens extraction. So to talk about the cutoff, I usually keep as IC depth in ICL is 2.8 microns and white to white is 10.65. And with regard to clear lens extraction, it is nothing but we usually consider it for an age more than 40 years. And here we have the EDOF lenses, and with regard to application of multifocal lenses can be considered all based on the higher order aberrations and the patient's need. And with that, thank you.
Thank you, Dr. Shaji. That was quite comprehensive, and I'm sorry for the initial hitches that you had to face. Anyway, it was good work under tremendous pressure. In this respect, I just wanted to ask Narayan Kute sir, because he's someone maybe amongst the entire crowd who has been doing refractive surgery for the longest time, and you have seen the entire, wave come and, change. So, in brief, what would be the most remarkable change that you have seen? I mean, is it the thinning of the flaps, or is it the lessening of ectasia, or what, in your words, would be the most remarkable change that has happened in refractive surgery?
Remarkable change is the case of flap only. Because unless you are not very much experienced, the chance of getting complication when you use a motor for the flap making, it is more. So that is because a less number of complications are there. The one thing, that practical problem that we face is a major portion of elastic people, they are either mainly people going for employment or people who are getting married. So that age is 18 to 21. So in our institution, we have made the cutoff at 18 years, not 21. Because of that, the demand, and if the power is stable for the previous 2 years without any change, I don't find any problem by taking persons above the age of 18. And in our institution, we also go for LASIK up to -8, provided there is adequate thickness of the cornea, because 300 micron definitely will keep as residual cornea.
And I think one parameter should be the K values also, if they are not too flattened by the laser.
K value is a very important thing when you are using motor, keratoconus.
I think Dr. Shaji explained that quite well. Any questions for Dr. Shaji?